So Lenny and Elaine called and said, would you like to come speak? And I was, the topic initially was talk about T-cell targeting therapy. And then when it all came through, an email came through, they threw me the hook and said, well, let's talk about transplant too. And as a transplant surgeon, obviously, I know an awful lot about transplant immunity, so we'll talk about that at the very end, but we'll get to that. These are my disclosures. None of these are related to transplant. This is what I'd like to talk about, and we'll sort of walk through this. I'll just show you this, and we'll sort of go through the rest of this. Why are we targeting T cells? What's the point of targeting? And we've heard about a number of other targets earlier today. Given that, how can we target T cells? And then we'll sort of move in, and much of the talk, I'm going to talk about existing therapies. Now, there's an S on the end of that, and the challenging part of this talk is that there really shouldn't be an S on the end of that, because there is only one T cell, real effective T cell targeting therapy that we're using today, at least in the biologic realm. Existing therapies in other rheumatic diseases, we'll get beyond RA a little bit. I will talk about transplant. I'll tell you a little bit about where they're thinking about this, and it does make some sense, and we'll cross over. And then briefly at the end, where are we going next? So this just kind of sets it up, and you've heard a lot of this morning and in other areas, and sort of why are we targeting T cells? And certainly in RA, there's no question that there's an inciting event that's the antigen presenting cell, the T cell talking to one another, and clearly this gets the whole process started, and it makes sense to sort of start as high as you can on the food chain if you're going to try to target the disease process. When you think about targeting T cells, there's a number of ways you can go after a T cell. T cells express a number of things on their cell surface. So if you think about biologics and what you can use, for a lot of years, people have sort of looked at the CD4 positive, the helper T cell as a target cell, and perhaps targeted even the CD4s expressed on the surface, which I'll mention. There are other molecules. And then ultimately, we're going to get into this whole concept of co-stimulation and some of these co-stimulatory molecules that sit on the surface and whether they may play a role in how you actually target the cell once you've established that as a cell you want to go after. T-cell therapies are not new. There are a variety of failed therapies that have been out there for years. As I was training, there were still papers coming out on why thoracic duct drainage was not an appropriate treatment for rheumatoid arthritis. Now, in retrospect, I think all of us would say that's probably never wasn't appropriate, but it was tried. Total lymphoid irradiation, which actually made people better, but ultimately ended up with a great number of lymphomas and leukemias and hematologic malignancies after that. And those were essentially T-cell targeting therapy because they work by suppressing lymphocytes and primarily T lymphocytes. There was a brief look at alemtuzumab, or Campath, which is an antibody to a cell surface molecule, CDW52, which is expressed on a number of mononuclear cells, and including T cells. There was some evidence of efficacy in RA, but those patients ended up profoundly CD4 cell depleted for many, many months, and if not years after treatment, and it was a big problem. And then there was a lot of interest for a while in anti-CD4 therapies, specifically targeting the CD4 on the cell surface, none of which worked. And I think in one of the ways, those were sort of instructive, not so much for the target, but in many ways for clinical trial design, because a lot of these trials looked really good in open label therapies. And then as soon as they went into a controlled blinded study, they didn't work. And it was first anti-CD4 antibodies and then a couple of different non-depleting anti-CD4 antibodies ultimately didn't go anywhere, which led us finally to this step, which is the concept of targeting the co-stimulatory process in the T cell. And so if you're thinking about an antigen-presenting cell and a T cell, or a dendritic cell in this case here, you've got the cognate interaction between the major histocompatibility antigen on the cell surface, the antigen itself that's driving the immune response, and this clonal T cell receptor, or the T cell receptor of interest. That signal alone is not enough, and you need a secondary signal, and the one that's been probably the most well described and the most understood is this cross signal here between CD28, which sits on the T cell, and CD80 and 86, which sits on the antigen-presenting cell. Those people who've done immunology years ago, this is B7 and B7 ligand, and the terminology changes over the years, if for no other reason than to confuse us. And the role of this is really, in many ways, it's a way to prevent T-cell overaction. So what happens is there's a second signal, the CTLA4, the CD28 binds to the CD80 on the antigen-presenting cell. You get that second signal, and one of the results of that is that an activated T cell begins to express more CTLA4 on its cell surface. CTLA-4 has a much higher affinity for this ligand on the antigen-presenting cell. It displaces the CD28 that started the process in the first place, and when that does, and that ligation happens here, now you get a downregulatory signal back to the T cell. And it's a mechanism to prevent essentially the T cells from getting continuously stimulated and continuously activated. And with that in mind, that's what led to the T cell therapy that we're looking at right now, or one of two, and I'll show you the slight difference between the two. This is abatacept, and fundamentally this is a fusion protein, much like some of the other fusion proteins that we've seen, which takes a piece of that CTLA-4, which is the molecule that has that high affinity for the antigen on the antigen-presenting cell, for the cell surface CD80 or 86 on the antigen-presenting cell, attaches it to the FC fragment from a human IgG1, the constant region, and you get what is essentially a fusion protein, sort of fundamentally an artificial antibody, if you will, that's going to bind to that CD80-86. And so now what happens is that you get this process. When you get the abatacept in there, you prevent the initial activation of the T cell. Okay? So it's not a T cell that gets activated and then downregulated. It's a T cell that never gets activated in the first place. You look at that and you think, well, that's interesting. How is that going to work in rheumatoid arthritis? And one of the things that's interesting about it is you look and say, well, if T cell activation is high up in the food chain, it's high up in the cascade that drives disease activity, this is a therapy that should work much more effectively very early in disease. It may not work later once the disease process has gotten started. And for reasons that I'm not sure I understand, but are continuing, it isn't the case. It works throughout the disease process. This is the first study that came out. This was the phase 2 trial in RA a number of years ago now, about 10 years ago, that looked at a couple different doses of abatacept. This is CTLA-4 Ig, that's abatacept back then. That's the CTLA-4 with the Ig fragment. This is another construct, which we'll come back to, that's now known as belatacept. Okay, that's LEA29Y, that was the name at the time. It's very similar. It's got 2 amino acids different, but it's essentially the same construct with slight difference, and we'll come back to that. And in this original phase 2 trial, they looked at several different doses of each of these, and the bottom line was that both, particularly at this 10 milligram per kilogram dose, were more effective than placebo, and they seemed to be equivalently effective. There wasn't any real substantial difference between the two molecules in this original study. That said, this is the molecule that went forward in RA. This molecule went forward in transplant, and I'll come back to that in a little bit. And here's where we went in RA. So the next step was to look at this in a larger study, in a phase 3 trial of methotrexate non-responders, and lo and behold, this worked as well as some of the anti-cytokine biologics, giving you ACR 20, 50, and 70 responses that were comparable to that. And here you see 6-month and then 12-month follow-on data. And then there's the X-ray data from that same study that showed radiographic inhibition. You have to be a little bit cautious when you look at X-ray data across studies because it doesn't look like you get the same kind of degree of inhibition that you might get with a TNF inhibitor, for example. But I'd be careful because the way they were doing the sharp scores was a little different, and it's a little bit different study. It's clear, though, that this is a molecule that inhibits X-ray progression. That's the best you can take and say out of this. And then the next step was to look at this molecule in TNF non-responders, and here you get a response rate that is less than in the methotrexate non-responders, so the people who are TNF naive, but still sufficient response to say this is an effective molecule in this population. And you see ACR 20, 50, and 70 response rates in that population. And this is from the extension of that trial, which I think points out something somewhat interesting about this molecule, and I don't know that we actually, I don't understand the answer to this, and I think that it's something we continue to watch. And this is the long-term efficacy, and on the top you see DAS, low disease activity, here you see DAS remission, and here you see HAQ scores. And I think it's fascinating here that in this trial where you have a long-term open label extension, there seems to be a continued increase to a certain extent in some of the higher levels of response in the patients on remission and low disease activity. You have to be careful about making too much out of a long-term extension like this because it's open label, and these are people who stayed on the trial because they were doing well. So you would expect continued response. There's no question about that. But in most of these kind of graphs and these kind of trials, you see a fairly flat line once you get past about a year or so where the patients who are doing well stay in the trial and are doing well. This one is one of the few that you actually see that line going up a little bit over time. And to me, that suggests that there may be, even though this is potentially a molecule that hits sort of early in that cascade, that maybe over time you have some impact on T cell activation that leads to further response. Don't know that yet, though. Just to point out, so all those trials were done with intravenous drug. There's a subq preparation that just came out within the past year and a half or so. And this is just to point out that it's exactly the same, that subq in this, and they've done, in follow-up to what Ed just talked about in terms of immunogenicity, they've done immunogenicity studies, and there's no real difference between the subq and the IV. It's an effective way to go. So that's T cell targeting. Where does that fit in the whole schema of things in terms of managing RA? And this is one of the first studies, this is actually the first study that looked at that, which was abatacept versus infliximab. This was done in Europe. They used 3 milligrams per kilogram of infliximab. So they used the approved European dose. It's a sort of low-dose infliximab. But at the end of the day, the two drugs were similarly effective. And safety actually seemed to favor abatacept a little bit, and I'll come back to safety in a second. We talked about abatacept, but overall fairly comparable. And then this study, which has just come out and just been published, which is the real clear head-to-head blinded study between targeting a T cell and targeting a cytokine. And this was abatacept study versus adalimumab. So adalimumab, anti-TNF. These were blinded patients who received subq dosing of both drugs, once weekly abatacept, once every other week of adalimumab. And the take-home from this was that these drugs were equally effective. And interestingly, not just in terms of total response, but in the slope of that response, and that the response was at least as measured by the ACR response criteria in terms of ACR 20, 15, 70, the slope was about the same. It was equivalent in the two. And interestingly, radiographic, and I don't have this labeled properly, but this is the radiographic data from this study, and it shows that the radiographic response was exactly the same in the two. So the takeaway from this is that abatacept is equivalent at targeting a T cell, in RA at least, seems on the face of it equivalent in a population of methotrexate non-responders to targeting a TNF inhibitor. That's an interesting concept, and one of the things that I don't entirely understand, and maybe there are probably smarter people in the audience than myself, including maybe Michael, who was the first author on this, who might be able to tell me why targeting two completely different places in the pathway of the disease gives you exactly the same clinical response. And that's sort of an interesting concept to me, and I don't really understand the takeaway on that. That's RA. I was charged to look at autoimmunity, so other rheumatic diseases, other autoimmune diseases. Spondyloarthropathies, not so much, and this has been a challenge. And this, I think, points out that it's interesting when you think about looking at targeting TNF in rheumatoid arthritis and in spondyloarthropathies, you get a solid response in both cases, but clearly the pathophysiology of those two different populations are different. And in this case, looking at abatacept and ankylosing spondylitis, there was essentially, in fact, except in the patients who were TNF naive, where you saw a little bit of improvement, there was essentially no response in this small pilot study. Not nearly enough to even consider looking at this in a larger study. So this was not an effective drug in AS. It has been looked at in psoriatic arthritis in a little greater depth, and this is interesting because one of the earliest publications looking at CTLA-4 Ig or abatacept in clinical therapeutics was actually in a psoriasis trial, a pilot study in psoriasis, and it never went forward in psoriasis. But in psoriatic arthritis, this was the data from that trial, looking at 3 different doses. This is really the commercial dose that's out there now that's equivalent to about 10 milligrams per kilogram. They also looked at perhaps loading to try to get a greater skin response early on and then a lower dose. And you can see that it was effective. It doesn't appear, and again, it's challenging to compare cross-trial, not as effective as we might expect to see with a TNF inhibitor, for example, in this population. Importantly, in the population where we would need something like this, and that's the psoriatic arthritis patients who failed the TNF, they did least well. And so in the patients who had previously seen a TNF, there was a very marginal improvement relative to placebo in this study. Whether we'll be able to see any more with the subq dosing on this and adjusted dosing, I don't know. There was a marginal benefit in skin disease in this study as well. So not nearly the same kind of response that you see as in RA patients. And then lupus, and we heard some of this from Dr. Lipsky earlier, and sort of the role for targeting this T-cell, B-cell interaction in lupus. And in the 2 studies that have been published to date, this was not an effective approach in lupus. So in the larger study that looked at lupus sort of globally, measuring the different manifestations of disease from arthritis to skin lesions to serositis, there was no benefit with abatacept versus placebo. And then in a second trial that hasn't been published yet in a peer-reviewed publication in lupus nephritis, the comparison was mycophenolate plus abatacept or mycophenolate plus placebo, and there was no benefit except that in the small population of patients who had nephrotic range proteinuria, there was some improvement in protein, but overall, there was no significant benefit. Challenge of these trials, like so many of the trials in lupus, is whether this was really the fact that this target is not the appropriate target or whether it was really trial design. But at the moment, we don't have any data to support this in this disease. Let's turn to safety a little bit briefly. Like any other biologic that we've seen to date, the most important concern has been serious infections. This is a meta-analysis of the 5 initial studies that were done that suggested a small but not statistically increased risk of serious infections with these drugs. In the larger Cochrane review that was just published about 2 years ago, looking at serious infections with biologics across all disease states and therapies, abatacept did not show a significant risk of infection, nor in fact did any of the other TNF inhibitors or other biologics, with the exception of certolizumab, and there were some issues on the way that data was captured here. Interestingly, though it was not significant, there was a somewhat lower risk of infection with abatacept compared to some of the cytokine-directed therapies in this analysis. Whether that's real or not, I think we need ongoing information to tell us that. What we do know is that, and this is one of the drugs that has showed us that combining biologics can be a risky and a little bit daunting proposition. And so we do know from the one large study that looked at combining a TNF inhibitor, abatacept, with other DMARDs, whether they're biologic or non-biologic DMARDs, in the group that got abatacept and other biologic DMARDs, there was a higher risk of serious infection. The numbers were small, but clearly a numerically higher risk of serious infection. And the same thing showed up in a smaller trial looking at a combination of etanercept and this drug, specifically in a similar population. The same, just about doubling, numerically doubling risk of serious infection, which I think warrants caution. In terms of other safety issues with targeting TNFs, it's interesting that beyond serious infections, we continue to worry about opportunistic infections or atypical infections with other biologics and with other cytokine targeting drugs. COPD and complications of COPD was something that showed up in the earlier clinical trials and has not really shown up in any large issues in terms of some of the registries since then. Autoimmune syndromes, paradoxically, psoriasis, again, like we've seen with the TNFs, same kind of thing has shown up with this drug. And we have not seen to date any solid evidence of malignancy concerns. But the the opportunistic infection story is kind of interesting. Has not really shown up and may be different than certainly the TNF-directed therapies and some of the other cytokine-directed therapies. This was a paper published a few years ago that looked at a mouse model of Mycobacterium tuberculosis. And if you took these mice, infected them with this MTB, mice that were treated with a TNF inhibitor had significantly decreased survival. They lost weight and they died, whereas mice that were treated with abatacept actually survived much longer. And so the question is whether abatacept interferes with this response or not. It may not interfere with response to mycobacteria. Now, I would caution that this is mouse data following Dr. Keystone, who often tells you that when a mouse walks into his office, the mouse data is useful. I don't know how that translates into people, but for mice with TB, that's an important issue. And whether it translates, we don't know. The last thing I'll say about safety is vaccinations, and clearly the concern about antigen presentation in terms of vaccine response is an important concern. There is some data out there that sort of is on both sides of the fence. This is some data on pneumococcal vaccination response, and it's not labeled properly, but these are patients who had not received abatacept, had gotten it 2 weeks before the vaccine, 2 weeks after, and I think 6 weeks after. And the end-up take-home was that there was some abrogation of response to the pneumococcal vaccine, but not enough to say that the patients didn't respond. And most patients had at least some meaningful response. On the other hand, in a very recent publication that looked at response to the H1N1 vaccine during the pandemic a couple years ago, the suggestion was, in fact, that patients who were on abatacept did not have a serologic response to that vaccine, or did not have a significant, meaningful serologic response. And so it does raise the question about whether this is going to interfere with vaccine response. And I don't know that it's a question that we've answered just yet. So let me turn the last couple minutes to transplant. What about transplant? Well, the concept makes sense that says if we're using these drugs in autoimmune diseases because the fundamental issue is T-cell activation based on antigen presentation of some as yet unidentified antigen. In solid organ transplant, we know what the antigen is. I mean, there is certainly clearly an antigen that is the foreign organ that's been transplanted. And so there has been great interest in looking at this pathway as a target to treat people at post-transplant immune therapy. So what is this drug? Well, belatacept is kind of a second generation. As I showed you, it was there at the first generation, so it is similar. It differs by just 2 amino acids from abatacept, from the CTLA-4 Ig construct, but that difference actually gives it a somewhat higher affinity for CD80 and 86, and that number depends on how you measure that affinity, and like so many of these kind of ways of testing it, sort of depends on sort of the system in which you look at that, but it clearly has a higher affinity for those molecules on the surface of the antigen-presenting cell. It also has a slower off rate, so once it binds, it sticks a little better, so it's going to interfere with that second signal that binds to CD28 on the T cell. What's the rationale for why this would make more sense in transplant than in rheumatoid arthritis, or vice versa? I don't know, actually, and I'm not sure there is a clear rationale. I mean, a drug that has a higher affinity for CD86 would seem to be just as useful in RA, where that's the interaction that you're trying to interrupt as well. I think, frankly, the rationale was more business-oriented than scientific in terms of this, but that's the deal. So we have 2 different drugs, one of which went down an autoimmune rheumatic pathway, and one of which was taken down a transplant pathway. And here's the difference here. So you've got essentially the same drug with, again, these 2 amino acid substitutions in that CTLA-4 region. What's the value in transplant? Well, the value in transplant is not so much about preserving organs, because they've actually done, and particularly in renal transplant, where most of the data is, that data is quite good, and those patients do quite well over a long haul with current therapies. It's about toxicity of the other immunosuppressive drugs. And so the standard drugs in transplant these days are calcineurin inhibitors, either cyclosporin or tacrolimus, and one of the biggest problems with both drugs is nephrotoxicity. And it stands to reason that if you're doing a renal transplant and you need to sustain that patient on a drug with nephrotoxicity, that's not an ideal scenario. And so the major trials looking at the use, and this should be belatacept, this was sort of a Freudian slip here, this is belatacept in renal transplant. What happens is they get the same transplant survival rate, but what you see is GFR is sustained better in the group that got belatacept compared to the group that got cyclosporin. Okay? There was also some impact, lower impact on blood pressure. So hypertension is an issue with cyclosporin, again a concern in a renal transplant population. And the belatacept group, and again I've got the slip here, it should be belatacept. Even though they used more lipid-lowering and antihypertensive therapy in cyclosporin, there was still a difference. There was less blood pressure issue and less lipid issues with the belatacept. They went on to do larger phase 3 trials, and these are the 2 trials that looked at a couple different doses of belatacept and cyclosporin. They use these are transplant criteria, and so the standard criteria are people who basically are good candidates for transplant. The extended criteria are patients where the donor organ was not the perfect transplant, so they look at those as a separate group because at least in terms of graft survival, the outcome is likely to be different. But you can see here that compared to cyclosporin, you see differences here in GFR. With the two different groups. So same survival, similar graft survival, but less impact on GFR. There was a better cardiovascular and lipid profile in the treatment group with belatacept. Infection and malignancy was the same. The one increased risk that seemed to show up with the belatacept with T-cell targeting was post-transplant lymphoproliferative disorder in a small number of patients, particularly with the high doses. And so they struggle in transplant now to try to balance those two risks out. When they follow these people out long term, this is a 5-year extension study, the same graft survival. There are actually more serious infections and serious cardiovascular complications in the patients who get cyclosporin, no difference in malignancy. So the role in transplant is not so much that it improves transplant graft survival again, but it improves other comorbidities and other complications and toxicities in the transplant patients. And in the last second here, we'll talk about, so that is T-cell targeting as we know it today. What else might potentially be out there? Well, there are a couple other targets that are sort of in use. Alemtuzumab, which is the CAM-path antibody that I mentioned earlier, way back when tried in RA, is actually still used as a depleting antibody. CD52, which is the target, sits on mononuclear cells, particularly on T cells, and it's a depleting antibody that's used often for induction in transplant settings and also as treatment of acute rejection to sort of stop that dramatic immune response. There are two other antibodies out there, or have been out there, against the IL-2 receptor on the T cell, or CD25, which is the IL-2 receptor. These are used for induction in the transplant setting. They have been shown to reduce the incidence of acute rejection post-transplant, but they actually don't have any impact on long-term graft survival or complications. There are two of them. The one that's currently in use now is this basiliximab. Daclizumab was actually pulled off the market, and that was a business decision that actually had nothing to do with safety or efficacy. There was just not enough use of it, so they stopped manufacturing it. And then finally, CD40. So one of the other potential second signals between T cells and B cells, between antigen-presenting cells and T cells, is CD40 and CD40 ligand. Some of you may remember a number of years back, trials of an anti-CD40 ligand in lupus. Those trials were stopped because of a number of thrombotic events, and the problem was that there's expression of this ligand on platelets, and that seemed to be the issue that was causing that problem. There's some interest now, not in anti-CD40 ligand, but actually in anti-CD40 antibodies, although that's kind of early in the process. And with that, I think I have wrapped this up on time. Happy to take any questions. I guess I would say I don't have a conclusion slide because there's not much conclusion to be made. We have one drug. I think that it's clear it's effective in our autoimmune diseases and our rheumatic diseases. Interestingly, similarly effective in transplant. Why the difference between the two, I can't explain other than it's a business thing, but both work. And that's where we're at.